Alrighty, hi everyone. Oh, were you gonna say something, Tristan?
I was just like, go ahead.
Okay, good. All right, hi everyone. My name is Taralee Hamner. I'm a pediatric neuropsychologist at the Children's Hospital of Philadelphia. I hope you all caught the eclipse. We had a very brief moment of it before it got really cloudy here, so it was cool to see for a moment. But I'm excited to be here today to talk to you all about bits of neuro, so the neuropsychology of babies, infants, and toddlers. And this is something that I'm really passionate about, and I'm glad that this was a requested topic because when I was in training, I definitely didn't have access to any sort of formal training in this, and I think it's emerging in the field. I'm actually the one of the work group directors of for the sorry, INS SIG, that's the word, for the Bitsy SIG. So if you guys are interested in what you hear today or you want to learn more, my email is in the slide here and at the end, and I'd love to chat more informally or through the Bitsy SIG. All right. So brief agenda for today. We're going to go over an overview of early development, talking about brain development, this idea of developmental cascades, milestone attainment, and developmental domains that we assess, talk about the different assessments that we use, some current interventions, and then a little bit on my current research in this area if we have time. Before we get started, if you're willing, if anyone knows about Slido, you can log in and type in this code, or you can scan this QR code and just give me some information about who I'm talking to, what experience you have with this population. I'm curious if people are working with young kids or if you're primarily working with older children and not yet seeing this population. So I'll give it a minute to load. And you can click multiple options. You don't have to commit to just one. Nice. So we've got a good range, some adults, some young children, and then that middle range there. Well, thank you for completing that, guys. So it looks like, yeah, some of you are familiar with the young kids, but mostly looking at school age for the child group. All right, so why do we care about baby brains? I have to say I've spent more time than I should convincing other disciplines that babies do indeed have brains and that we can assess their functioning through different neuropsychological measures. And so typically I think people think of much uh, older children when we talk about neuropsychology, but we know that the brain develops very early on. And so this is a chart of brain development in utero. So looking at neural tube formation, happening before many even know that they're pregnant. And then this gives way to neuronal migration, all within the first trimester, then leading to structural formations beginning in that second trimester, which is one of the most critical parts of pregnancy for brain development, when any sort of teratogens or anything that can impact the developing brain is going to have a really big impact in that second trimester, which then gives way to the really huge growth spurt we see in that third trimester when the brain doubles in size and begins myelination. And so we'll talk a little bit about prematurity later on, but just within the context of the developing brain, so much is happening before they even arrive at the world. And then when they do arrive, we really see this takeoff of their neurocognitive processes. So this chart here looks at human brain development and the neurogenesis that occurs. So how rapidly the brain is growing, having new synapses and neurons connecting in that first year of life. So left of the gray bar, that is all months. So very condensed amount or very spread out amount of time compared to the years that we see later on. And in this first year, over those first 12 months, we see this really rapid development of sensory pathways, of language, and even higher order cognitive processes that develop in this time before they then begin to prune into what we know as our neurocognitive functioning that we assess in older children. And so a lot happens in that first year. It's a really special period where we can set kids up for really great development as they get older. And I think something that's really interesting about this is that all different kinds of environmental factors or biological factors can pop up and shape development from an early age. And so we might think of iron as an example of if you have an iron deficiency early on in utero or in the first year of life, we're going to see deficits in cognition, so in our actual IQ scores. Whereas if we have iron deficits later on in the toddler years, we'll see more hyperactivity and inattention symptoms. But then these iron deficits later on in adolescence are going to relate more to mood problems. And that just kind of gives us a nice stage for thinking about it's not just that we have an iron deficit or an impact or whatever it may be. It's about when is it happening in time and where is the brain in its developmental process. And so we all probably think developmentally, but it's even more important for our babies' brains. And this is another illustration of iron in particular, showing that iron deficiency at birth is related to lower cognitive scores and that this persists over time. And there's this quote that if we fix iron deficiency across the world, we would raise the world's IQ by about 10 points, which is a really impactful statistic to me that we can have interventions on later cognitive outcomes very, very early in life and very important to think about. We also know that executive functioning is really being formed in the very early period. So we think of, again, executive functioning in teenagers and adolescents and young adulthood and beyond, but all of this is beginning to develop in that toddler period. And so this happens when the brain is most flexible and still laying down and reinforcing the neural pathways that will be in place for life. And so this means that between birth and 5, there's the most potential for developing healthy executive functions. And after all, it's when the brain has the most rapid development. And evidence is showing us that if it's not developed well in this early period, then we're going to have problems later on. And so I think very few people think about infants as having executive functioning, but we actually do see different developing executive functions in these ages that we'll go over a bit more on the next slide. But we know that the prefrontal cortex is particularly sensitive to change through this learning and practice that we see during early childhood and infancy. And so thinking about these 3 domains, we have working memory, happening as early as 7 months, where children are remembering that there's an unseen object under a toy that's hidden or a washcloth and able to put together sequencing to be able to obtain that item. This progresses into executing simple task, 2-part task, or knowing how to look, orient, and reach to something, and then also keeping 2 different rules in mind. So I know that the red is over here and the blue is over here, and I can sort and use my working memory in that way. Inhibition control, we also see very young at about 6 months, where children are able to stop their reach. So when they're really interested in something in their environment, they're able to inhibit when told to. And then also when they have distractions in tasks, they're able to persist. So even though that there's an exciting task going on, we reduce our focus and there's a distraction or a delay, they're able to still persist. This then gives way to other inhibitory control that we see where they can notice that there may be a barrier between them and a toy, and they're able to restrain themselves from still trying to get it and coming up with maybe different ways to access it. And then you're probably all familiar with delayed gratification, but that's also something that we start to see emerge in this time period, as well as cognitive flexibility. So again, developing alternative methods to get to something if it's not able to be accessed in the way the infant might think, and then shifting, understanding that certain rules are for certain places and that I can be flexible and follow different rules that I am taught. And so the model that I really like when I think about early brain development is this idea of starting states and developmental cascades. And there have been a lot of pioneers who have done research in this area, but someone that I particularly am fond of is Annette Karmeloff-Smith, who wrote in 1998 about development as the key to development itself. And this is a paper that talks about starting states and developmental cascades, being that we know that the initial conditions that a baby is born into when they're beginning their developmental journey is going to consist of both genetic predispositions and their environmental influences. And that children are born with different innate cognitive structures and capacities that are setting them up for the rest of their life. And then those starting states are impacted by further developmental cascades that happen. So development, as some may tell you, is not actually linear, but it's unfolding in this really complex manner. And understanding these dynamic and interconnected variables, it helps us understand how development unfolds over time. And so changes in one domain at one point in time don't just happen in this one domain at this one point of time. This is now going to impact what happens many years later and in different domains. And it's this interconnectedness, this developmental cascade by which we see children grow their brains. So each milestone is building upon previous milestones, and it continues to be influenced by internal and external factors. This is an example of developmental cascades from Jesse Bradshaw's group down in the University of South Carolina. This paper actually focuses on autism, but what I think is really helpful about this paper is it shows us pretty clearly how a developmental cascade may unfold from motor planning all the way to language development. And so again, those are different domains at different time points that are interconnected to see skill acquisition happen. And so we can see here that when we think about motor skills developing, we first have a child who's laying on the ground and are starting to become aware of the environment. And this gives way to another motor skill, which is sitting and exploring their space. And once we're upright and we're exploring our space, we now have another cascade of parental or caregiver involvement where they're commenting on what's happening around you, labeling things. Maybe the child starts to show things, and that label becomes language. And this is how children go from simply motor planning, right, sitting up and that sort of thing, to now having language and interacting with their world. And so when we think about this within the neuropsychological context, we can take reading, for example. If we want children to be good readers in third grade, where do we start? Right? It's not just that they enter a school and all of a sudden we expect them to be good readers. The foundation is being laid for that well beyond then. And what we can see in the literature is that, yes, toddlerhood is a really important time for developing pre-literacy. And there's actually evidence now that we can predict third grade reading ability based on a 2-year-old's white matter myelination and their left arcuate fasciculus. And so that's really important for thinking about these pathways do not all of a sudden show up when you come to kindergarten, but that we're laying the foundation from there. And thinking more about this in the context of developmental cascades, it's not even preschoolers that I'm thinking about, or even toddlers. I'm thinking about like infants who were just born, right? So this is a picture of a baby in a NICU. You can see they have their feeding tube there. And they're with their mom, and they're having this beautiful contact and this bonding moment, the safe, nurturing space where the mom is introducing language and communication. And this is truly the cascade. This is what's setting up the foundation for children to be good readers. And we can take this and apply this to many different neuropsychological processes. But really, the underpinning commonality is that we really need to be promoting healthy brain architecture. And what does that mean? So Harvard has done a lot of research into this area, talking about what healthy brain architecture is comprised of. And so we know that it's based on positive caregiver interactions, availability, warmth, kind of this ping pong or serve and return model where children are having this dyadic interaction with their family or their caregivers, and it's reciprocal in nature. And it's dependable and it's consistent. So thinking about attachment theory that some of you may be learning about. Healthy nutrition, we touched on earlier with the iron deficiency, but there's many, many others are all absolutely critical for setting our brain up for success. And then we now know that stress, yes, even stress on infants exist, and that this is really impactful for the way that the brain develops over time. So an example of some healthy brain architecture that I love to show is this video. Some of you may have seen it. It's an oldie, but a goodie. I'm sure this kid is like 6 or 8 now. I don't know. But this dad and this child are having a beautiful interaction. The child is pre-verbal. The child does not have language, but as so much is being communicated.
Verbal everything. Yes. Did you understand it though? No. Okay. All right. All right. Not this one. This one's for granted now. The other stuff. Yeah, that's right. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking. Oh yeah. Right. Don't bring that in. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah, I was thinking that. Yeah. Like go somewhere else with that, but don't bring kids. You know what I'm saying? Yeah. That's what I said. He was like, you know what I'm saying? And I was like, what in the world? Don't do that here. You know what I'm saying? Yeah. 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 Really? I done the same thing. We think a lot alike, huh? Oh, that's crazy. Right.
All right, so I love this video. We saw so many beautiful things happening here. This is like a great example to show families about what interaction can look like with a child where demands are really low. We're not quizzing them. We're not saying what's happening or show me this. It's really just about interacting with the world and what's going on around them, waiting for responses. So taking pauses, not trying to fill the space, letting kids come to you. We saw so many beautiful gestures, the pointing, the what, the reaching, the social referencing of dad to the TV and the person taking the video back to the dad and having this really nice pre-verbal exchange. Clearly this child is, getting lots of exposure, lots of wonderful enrichment activities that is helping this child learn language. And so, oops. But I will talk about screen time for a minute. So even though they were watching the screen and I'm talking about how great it is, I personally think screen time is one of the biggest issues that is going to come up for neuropsychology when we think about our young children. And so screen time recommendations have recently changed. The American Academy of Pediatrics, this is their new guidelines, where they say no screens for about a year and a half, avoid them if you can, but you can have social interactions with family or other folks through FaceTime and video calls, that sort of thing. And then from about 1.5 to 2 years, you can do co-viewing, but very minimally, and then an hour max is their recommendation. And that's great. And sometimes in clinic, I'm asking families, how much screen time do they get? Oh, not very much. But this study that came out last year actually quantified how much screen time they think children are getting by using a Lena language model that absorbs sounds in the environment and decodes different sounds. And they were able to decode digital sound to understand better what is screen time sound versus other types of sounds. And you can see here that even at young as 6 months, children are getting almost an hour of screen time. And then at 12 months, there's these violin plots show this really huge distribution where it just kind of rockets off from there. Children are getting 2 hours, 3 hours or more of screen time a day, all before the age of 2, which is really concerning for development. And you might be thinking, oh, she's a Luddite, she's against technology, it's not that big of a deal. But the research is showing us that it is a pretty big deal. If screens are what's occupying children, they're not doing other things, right? A child who's watching a screen is not playing, is not having an interaction with their peers, they're not learning how to put pegs in a hole or shape sort or all sorts of things. And this is supported by the research. So we're now seeing in the past 2 to 3 years is really blowing up literature looking at what effect screen time has on this age. And we're finding that increased screen time is related to neurodevelopment with increases in developmental delays, increases in attention and behavioral problems, lower full-scale IQs, lower language abilities, reduced self-regulation, and some of our early executive functioning, and then also decreased emotional processing and even social processing. And another paper came out last year too that's really beautiful, this path analysis highlighting the impact of screen time on neurodevelopment. But what's really interesting here is that they found, yes, at age 2, screen time was positively related to was related to worse communication at age 4. So going from age 2, following these children until age 4, screen time led to worse communication, poorer daily living skills, and reduced social abilities. But this was all mediated by outdoor play. So if children were able to get 1 hour a day of vigorous outdoor play, not just being outside, but actually heart pumping exercise outside, then this helped to diminish the impact of screen time. So there's something to be said for the balance, right? It's not, we shouldn't have screens at all. That's not really realistic in today's world, but moderation and then also balancing with other childhood activities. If you're looking for milestones, the CDC puts out one of our most comprehensive milestones that we have, but these were also recently revised in 2022. And so the CDC milestones now reflect what about 75% of children are able to do. And the reason that this change from 50% to 75% was to combat some of the wait and see approach that had developed in pediatricians' offices. And so no longer is it, well, let's wait and see how they're doing, milestones are based on 50% attainment. Now that it's 75%, we can act much earlier to help children. And the CDC milestones are a great recommendation for families because it shows actual videos of what we're looking for. So it's not ambiguous. And so this is a sample from their website where you can see a video clip of what it looks like when you hide a toy and they find it. They also have an app that's really great to recommend families where they can track this over time. And then they have play-based recommendations as well for families. In terms of milestones, I have some reference slides here that you all can go back to, but to see what we're looking for. But I think what's more important is what is missing and when that's a concern. So at 6 months of age, if they're not visually tracking or discriminating between sounds and others, and difficulty calming, that's a time when we're going to be more concerned. Between 6 months and 12 years, we really see this social takeoff. So more social smiling, more engagement, interested in play, and interested in other people. If children aren't showing that, or they're not talking, or they're having muscle weaknesses, that's another time we would be concerned. And then from 12 months to about a year, we really want, or 2 years, we really want to see children having increased functional play, doing lots of imitating, following directions. If they're not imitating, if they're not showing these play skills, we would be concerned. And if they start to develop difficulties with feeding or sleep problems or people. And then again, it kind of continues on with play and wanting to see those skills. And we're going to talk a lot about play in just a little bit because play is everything for children, right? Play is hard work, and that's how they learn. And so when we're missing those play skills, those social skills early on, we become concerned. And this relates back to screen time because when we have screen time, we're not developing our play skills and we're not developing our social skills. And so I like to talk to parents about, we want baby powered, not battery powered, as a kind of phrase for them to remember when they're thinking of activities for their children. So what does the infant or pediatric infant neuropsychologist look at? Primarily, we're looking at developmental processes. So many of these processes are not yet stable, and they're not even predictive of cognitive outcomes later on, but nonetheless are very important, and they change rapidly. And so we're looking at cognitive skills. We're looking at language skills in terms of expressive language or what children say. We're looking at receptive language or what children can understand. Gross and fine motor abilities, their adaptive skills, their increasing independence, and social and behavioral needs. And there's lots of different ways to do this. Observation and direct testing are probably two of our best, but it's also really, really important to be looking at caregiver report and caregiver interviews to get a sense of how the child is doing in other environments. And so let's talk about play. Play is not, an excuse to go have fun. Play is actually really hard work. Play is not a break from hard work. It is the hard work that kids need to do. And we know that play promotes cognitive growth. It helps with deductive reasoning. It helps with categorization skills, mastery, motivation, task persistence, self-regulation. It generalizes to later skills like feeding, dressing. All of these types of things are essential for helping children develop, and it all comes from play. And so when we're doing our assessments with children, we should be doing play-based assessments, right? Not sitting there, what is this? Show me this, sort of that type of thing. There is a place for that, but play is really speaking the language of the child and allowing us to assess them on their level and what they're interested in. It allows them to also just maintain control in this new environment. So if you're in my setting in the hospital, it's not always a fun place to be. And so having lots of toys and comfort, things that they're used to, can be really helpful in building rapport. Also, play is generally universal at the broad level, right? So we see kind of this developmental sequence of play, of cause and effect, of container play, of a parallel play, interactive play, that type of thing over time and in different cultures. And then it's also pretty generalizable with regard to behaviors and interventions that we may be recommending for families. These are some of the common tools or toys as tools that we use in our assessments. So baby dolls, blocks, stuffed animals, picture books, puzzles, balls, and musical instruments are things you're going to be playing with if you're not already doing this with children. It's a lot of fun. We can have a lot of fun with these kids. But there are challenges, of course. And so even more than in our teenagers or our young adults, we really need to be thinking about the timing of day, right? Is this kid usually in a nap at this time? Have they just woken up? Are they hungry? Have they eaten? What's the motivation or their attention? Like, what interests them? How do we keep them engaged? And also language differences. So we'll touch on this later, but many children who we see in this infancy toddler period have, if they are from a dual language household or even just a monolanguage household, they may not be exposed to English at all. So they may not have preschool, daycare, or any sort of educational setting where they are hearing it. So we're more likely to encounter children of different cultures and different languages at this age, where we're not able to do our assessment in English. And it's also important to think about multiple sources of information. So if a kid is throwing blocks, is it because the kid doesn't understand what to do, doesn't want to do it, or is this an entirely new toy and they're not sure how to engage with it? And then in our medical populations, it's important to note that there's a continuum of parent response. Some parents are overly vigilant and involved and would have intense concerns about everything. Others have significant apathy due to other concerns or ideas about their child's limitations. And so factoring that in when you're working with families is important. We talked a little bit about this, but just optimizing the environment, making sure that's at the right time for the child, being really flexible in this as well, being accessible and inviting, and making sure our rooms are pretty distraction-free and also projectile-free, right? We don't want too many things that can harm the child or harm ourselves in the room. And then thinking constantly about what are we seeing from a hearing and vision perspective when working with kids? Is there a hearing concern? Is there a vision concern? These are things that may not be picked up yet for these kids, depending on how they're followed and what settings that they're in. And so we want to be observing everything that they're doing as soon as they walk into our office, right? We're paying attention to how they transition away from their parent. We're focusing on that vision and hearing piece. We're looking at their rapport building abilities, their activity level, their language, and their motor skills, all just from an observation perspective, in addition to what we collect on our assessments. And then just a consideration to think about again is this family or caregiver-child interaction. So we know that this period that we're talking about, infants and toddlers, is a really particularly sensitive time to the effect of parent-child interactions. And it's really important to be able to identify any attachment issues or parent-child interaction issues. And we do have really good interventions to support children because we know when that is well supported, then the brain develops as it should or is on track and can continue to make gains and learn new skills. Parents should be a part of your evaluation. It's different where they're usually in the room with us, depending on the age, but we're not asking them to wait, in the waiting room or outside. They're really involved in everything. That can be difficult though, because you want to make sure that they're not naming things or labeling things or asking the child to do your directions in their own way several different times and going against standardization. So it's a balance, of course. It can be hard to test these interactions. Parents can be, of course, rightfully defensive about some of their strategies and reluctant to share what they find with their kids. And often parents are dealing with a lot more than just development, so being sensitive to that as well. Some of the most common assessments we use for infants and toddlers are the Mullen scales of early learning and the Bailey scales of infant-toddler development. You'll see here lots of those toys that we talked about before. And to give you just a little bit more information about them, the Mullen is based on, or it's for children who are first born until they're about 5 years, 8 months. And it looks at gross motor, fine motor, receptive and expressive language, and visual reception. So those 4 domains. And then it can compute this early learning composite, which is considered a developmental standard score. Again, we're looking at developmental progress, not intellectual progress at this age. Then we also have the Bailey, which is frequently used. This is from 1 month to 42 months of age. It has the domains of cognitive, so a bit different, and it has that piece. Language, motor, social behavior, and adaptive functioning. There's also a briefer screening test that's available that can give you kind of cutoff scores. Then some of you may be more familiar with these tests as we get into preschool age and above. We have the DOS and the WIPSI, and as well as the LIDER, which I won't spend too much time on these as these are frequently used in older children as well. There's also good assessments for early screening and school readiness. And so some of these are the Battelle Developmental Inventory, the Denver Developmental Screening, the DAISY, the Developmental Profiler, the DP4, and then the Bracken School Readiness Assessment, as well as some other ones here for reference. But when we think about the domains that we're assessing using any of these measures, it's important to think about what are we actually assessing at these ages. And so for cognitive, we're looking at the play-based ability to manipulate and explore their environment, to recognize things like object permanence, problem solve and reason, and to adapt to changes. And here we have some different examples of what this might look like at each age. So for infants, they're interested in toys, their attention to familiar, unfamiliar objects. Their play is changing from just manipulating or kind of interacting with something to more functional or relational play. And they show this early problem solving and object permanence emerging. Then in toddlers, we see increasing symbolic and pretend play. We see them integrating two objects into play or engaging with others. Puzzles, problem solving, more sustained play. And then in the preschool age, increased pretend play, becoming imaginative play, building blocks, doing more categorizations, so matching same different colors, shapes, that type of thing. For language, we look at both receptive and expressive communication separately because they have different sort of interventions that we use for them and different consequences. And so for infants, early on, we're looking at the recognition of sounds or others in their environments, identifying pictures or following very simple one-step directions, and performing social routines like high-fiving, clapping, blowing kisses. And then preschool age, it becomes more complex. For an infant with expressive communication, we really want to see smiling, sharing that emotional state that they're having, jabbering expressively, vocalizing. Toddlers, we would expect them to start putting together single to two-word statements, both spontaneously from their own or from imitation of what they're hearing others, so repeating after their adults in the world, naming objects and pictures or answering questions with yes or no. And then in preschool, they start to ask questions. So it's less of just commenting, but actually being more interested in answering questions related to what's going on around them. And then increased pragmatic language. Motor skills, again, our fine motor are small muscles. So we're looking at visual tracking, hand coordination, reaching and grasping. This gives way to more stacking, more evolved use of our fingers, scribbling, placing small objects into a container, and then drawing shapes or building with blocks or using scissors. And then for gross motor, we're looking at head control, sitting upright, starting to crawl, crawling, going into cruising, so holding onto furniture and kind of shuffling along, beginning to walk without assistance. And then we start taking steps and throwing balls and running and all the fun things. So those are some of our assessments that we use to look at these developmental skills. There's also something that's coming out soon called the NIH Baby Toolbox. And so there is the NIH Toolbox for children, I think 3 and up, but there's a conference going on today actually that talks about doing different assessments for children. I believe it's birth through 42 months. And so this is 30 different assessments that looks at cognition, motor, and social emotional domains. And what's important is that this is normed reference. So it's really a huge advancement for our field. It includes both direct testing with children as well as eye gaze. I'm not quite sure how they're integrating their eye gaze technology into the iPad assessment, but it's really exciting. And so this is just a sampling of some of the cognitive domains and language domains that you're able to assess really quickly using the NIH Baby Toolbox. So I think this has a lot of promise both for research and for our clinical settings. So to talk a little bit about intervention, I think I'm one of those people who believes that all of neuropsychology is intervention. We do assessments, but it's for intervention purposes. So even at our evaluation and in our feedback setting, we're doing a lot with families to help them intervene with their child. They spend the most amount of time with their children. They know their children the best, and we're giving them the tools to help promote different cognitive processes. Part of that is through really sensitive parenting and making sure we have the right fit for families with their child. So a lot of it is helping the adults understand how their child ticks and identifying what the parents are able to do to support their child. Different enriched environments are essential for children's development. So talking about what that might look like and quality early education are all important, just big picture things to be thinking about. There are specific parenting programs or different programs for children and families. So we have the Positive Parenting Program, or Triple P, Parent-Child Interaction Therapy, and the Incredible Years. Learning through everyday activities with parents, LEAP, and then I Interact is a new one that had been focused on brain injury, but now is expanding to other medical populations. And again, all of these are really parent-driven interventions to be able to help the child develop. Of course, we're also recommending, OT, PT, physical therapy, special instruction, all of those things. But again, the most bang for our buck often is with family. We can kind of shape some of that interaction. That's really lovely and easier said than done, but there's a lot of issues with equity and access, right? And so there's just from even our own assessments, there's issues with cultural biases. Many of our measures were not developed or normed on samples that adequately represent diverse cultural backgrounds and experiences of young children and their families. Our assessments do, unfortunately, other than the NIH toolbox, rely a lot on language. So even if I'm not asking the child to do something, I am using language and I'm still entering that into the assessment. And so children from multicultural backgrounds with limited English exposure may have lower scores. And is it because of some sort of neurocognitive process, or is it the bias in our assessment? At the policy level, we really don't have equitable access to healthcare, good quality childcare, and early education. I think families are just not well supported in today's world, and the level of stress and mental health needs are growing. And we know that these are variables that have a direct impact on a child's functioning. So really, to support a child's brain development, we need to be supporting the whole family at a societal level as well. A really quick overview of some of the medical populations you might work with. These are ones that I think come up a lot in this early age period, but it's certainly not exhaustive. There's many, many other populations that you may see. And so myelomeningocele or spina bifida is a group who neuropsychologists can have a lot of impact really early on. And so there's now in utero surgery that goes in and corrects the myelomeningocele while a child is still developing. And then the mom is able to carry the child to full term and give birth. And then from there, it's really important to monitor their development. There's a study called the MOMS study, or the management of myelomeningocele, which does show that this study or this intervention has really positive and favorable outcomes on children's development overall. Then in the perinatal stroke group, this is also a population who we should be following closely to make sure that they're well supported and meeting those milestones over time. Some of the interventions they may receive is the cooling or the induced hypothermia, which again is a neuroprotective intervention. But again, having a neuropsychologist involved who can track how each individual child is doing is important. The congenital heart disease group, they have a really wonderful resource called CNOC for anyone who's interested in this population that outlines different assessments that children should be receiving at different ages and what their developmental surveillance should look like. Childhood epilepsies are important to follow, and our role can be related to development, can be to different medication trials and seeing how that's impacting a child as well. Traumatic brain injury is not one I think a lot of people think about for our kids, but unfortunately they are at risk at a high rate for different brain injuries related to both falls and unfortunately abuse and trauma. And so this again is an injury to the developing brain where we can have a nice impact in supporting their recovery and ongoing neurocognitive development. And then of course, genetic populations, if it's identified early on for following these groups. I want to take a second, though, to talk about autism. In my experience, autism is often left out of neuropsychological education, and it's kind of an afterthought. And I think that's really too bad. We'll talk more about why in just a minute, but if we can go back to my Slido quiz, and if you guys don't mind letting me know, do you assess for autism? What is your comfort with it? Is it yes, routinely, when it's clinically indicated? No, I'm definitely going to refer out, or I just don't think it's relevant to my practice. And if it's something else, come off mute and let me know. Awesome. So you guys are identifying it when it's needed and referring out, or you're working with, or you're able to do it when clinically indicated, which is great. I feel like I was in a lot of practicum settings where that was just not the case, and it's kind of changing, but I do think a tool in our neuropsychologist tool belt should be autism assessments. And so for those not familiar, which I don't think this is the poppy in the group who's not familiar, but what is autism? It's a neurodevelopmental disorder that presents with really these core deficits in social communication, social interaction, and restricted and repetitive behaviors. And it's really important for us to be familiar with just in general as it's increasing in the population. And so we know that autism's current prevalence is estimated at 1 in every 36 children, which is pretty high. You see this dramatic increase over the past, I guess, 24 years or so, of 317%. And experts say that the bulk of this increase is a change to our growing awareness of autism, a change to our criteria for diagnosing it, but there are certain environmental and biological factors that play a role in this increased autism prevalence. There are some neuroanatomical correlates of autism that I think the group might be interested in, but I'm going to skip over this in the interest of time to talk about, you're going to see it, which you already are, so that's good. But we know that there is an increased rate of autism in most medical populations. So the general population is about 2.7%. And then when you look at our medical populations, we're seeing rates of 12% in epilepsy, about 12% in perinatal stroke, 16% in children who are born extremely preterm. Congenital heart disease is about 4%. Down syndrome has an increased rate in 6%, and then 22q is a population, which really I didn't put a citation here because there's so many different studies that say it ranges from about 15% to like 60%. So that is a population also at increased risk. And so very briefly, I want to have time for us to talk at the end, but I thought you might be interested in some of the research that I'm currently doing on sleep and neurodevelopment and preterm birth. And so kind of coming back to that, why the developing brain, and I had mentioned that the third trimester is when the brain begins its prolific neurogenesis and myelination, and it doubles in size. And we see that children are born before this is even happening. And so it's really disrupting the typical development of the CNS. And then children are placed into these NICUs where they have, pervasive interventions, flashing lights, beeping sounds. It's not very restful, right? And they're doing a lot environmentally to make the NICU a more neuroprotective place, but they are at increased risk from very early in life. And so we know that sleep maturation is one of the most important biological processes that occurs in the first year of life, and it does signal to some degree typical brain development. And so in the prenatal period, there are a lot of risk factors for this. In general, there's preterm birth that can have infections, hypoxic ischemic injury, and intrauterine growth restriction. And then this leads to reduced placental hormones at the time of birth. And this is going to have issues for neuroprotection, for neurodevelopment, and the regulation of neurotransmitters. This issue leads to the delayed sleep state maturation, reduced glia and neuron production and maturation, and impaired neural network connectivity, which once children are born, we see further impacts their sleep. So it's reducing sleep quantity and quality, more awakenings, delayed sleep onset, which can then in turn lead to impaired learning, memory, and cognition, as well as behavioral and emotional challenges. And so we know that it's related to these things in a typically developing population. And we know that children who are born preterm have increased risk of these difficulties. So it's believed that having sleep disruptions in preterm birth makes you more sensitive to the effects of this sleep problem. And for me, I go back to that developmental cascade. I think that sleep is a canary in the coal mine, right? It's signaling that something is happening, that it's also a low-hanging fruit. It's something that we can easily intervene with very simple environmental and behavioral interventions. And so I think this is really exciting that we have something pretty easy to address to promote cognitive outcomes for children. But to do this, we first have to understand the different medical and environmental risk factors, the nature and profile of sleep problems for these kids, and how these relate to development. And so this was the goal of a recent study that I looked at, where I wanted to identify the profiles of sleep challenges, examine the relationship with sleep and cognition, and then understand how sleep relates to different environmental variables. I saw children at 2 time points. I saw them from our early development clinic on fellowship, where that's our NICU follow-up program at age 3 and then also age 4. And these are all the measures we collected. Our children did not differ across these 2 time points on any of our variables here related to characteristics or demographics. And then our results. So what we found is that there is indeed an increased rate of sleep problems for children. These are Z-scores looking at them compared to the normative sample. And we're seeing higher rates of sleep anxiety, night wakings, and parasomnias for children across both age points. So they have these higher rates, and these rates do not change over time. They stay problematic for children. And for development, I looked at cognitive outcomes on the DOS, so one of those measures of early intellectual functioning. So we found that sleep problems at age 3 was predictive of the overall global composite. About 24% of the variance explained. It was not related to verbal skills, but it was related to nonverbal and spatial skills, accounting for about 27 to 28% of the variance explained. And then for all of these models, you'll see that current sleep problems at age 4 was not additionally significant. So it's really those early sleep problems having this cascading effect on neurocognitive development. We also looked at executive functions, so both task-based and parent-based executive functioning, and we found a similar story. These are trend level findings here, but sleep problems were related to different measures of executive functioning. And then same story with time 1 at age 3, problems being associated with later executive functioning across all the domains. And so what are some of the correlates here? We see that parenting stress is positively associated. Bedtime reactivity and consistency also play a role here. But surprisingly, there was no relationship with gestational age. So those born even more preterm did not show worse sleep problems. There was no relationship with medical complexity or childhood opportunity index, which was our measure of SES. So we can see here that the intervention points are likely really manageable, really something we can target in terms of parent stress and then bedtime routines. That's my summary that I'm just going to skip over because I said all of that. A limitation of this study is that we're relying on parent-reported sleep problems. So the next step would be to look at actigraphy, EEG, those types of things to really validate this. And that higher problems may just be overall interrelated. So if we're reporting a lot of sleep problems, we might report a lot of other problems. Some ideas for future research and an acknowledgement to my wonderful team who supported that research. And to close off the presentation, I want to leave you with some resources and opportunities to get involved in this population. Hopkins just had this wonderful conference called the Spectrum of Developmental Disabilities the first year, and they'll be doing that again next year. So that's a good resource to check out. And then, of course, like I mentioned at the beginning, the BITSI SIG, so the Babies, Toddlers, and Young Children through ANST. As I mentioned, I'm the leader of a work group for this, looking at assessment in this population. So if you like what you're hearing, if you want to learn more, please reach out and I can connect you to the SIG.
This was wonderful. Thank you so much. I do want to open it up to questions from the people in the audience. I have questions if others don't. One of the things that has always been, I'm going back and forth on while working in this population is the kind of input of parents in the moment, like in vivo observations and how to manage that. I think you alluded to a little earlier of like properly telling parents like please don't give the answer away, point, gesture. But I'm wondering if logistically you have some insight for the group of how to manage parent expectations for an evaluation in this age group.
That's a good question because it's easy to say it, but much harder to do. I think some of the very simple things like you're mentioning of just really telling them what to expect, kind of normalizing the situation of, I know at home they may do it one way, but when we have kids come into the office, this is, we're seeing how they react on their own without your help. If I need you, I'll call you over. Kind of being playful with it too. So like, I know you know the answer, but let's see what they know can be really helpful. And setting up the room where they can't directly intervene. So sometimes I'll have the parents sitting physically further away from the kid, with maybe me as the intermediate so that they can't kind of point or reach over and that sort of thing to help their child. It's not always the case. Sometimes you're on the floor. Sometimes the kid will only do it if they're in the parent's lap. So you definitely need to be playful, and just figure out how the parent is going to respond best to you.
Thank you. There is a question in the chat. So for families in urban areas or for those with limited access to safe outdoor environments, what are some options? What are some options we can provide for the rigorous activity reading is hard. Rigorous activity that we can recommend. Any recommendations for reducing parental stress for folks with such limited internal and external resources?
That's a really great point. And I love that you highlighted, not all kids have access to safe and outdoor activities. I think what's important to highlight from that study is that it's not the outdoor nature of it itself, it's a vigorous activity. And so that's thinking about, well, can we then use gyms or community centers or other heart pumping activities to help kind of ameliorate some of the effects of the screen time? And so I don't know if the researchers from that paper would agree with me, but I think it's more about getting physical activity than it is being outside. However, I do think there's power in nature and power in this idea of looking far, right? Not looking 6 inches in front of us at our screen, but taking in the entire environment. That also probably is related. So any opportunities for outdoor activity, I would definitely support. What was the second part of that? Parent stress?
Yeah, any recommendations for reducing parental stress for folks with such limited internal and external resources?
Yeah, it's a really huge question, a huge problem. I'm really lucky to work in clinics and settings where we have social work that's directly involved. And so for pretty much all of my kids that I follow in the NICU program, social work is also coming in to talk with family, to give ideas about resources, to provide mental health supports for family, those types of things. So if you have access to social work, if you can partner with them, they can be a huge resource for you as well. I think also just normalizing, right, what families are going through and coming up with that match between the parent and then the child's temperament and giving them ideas for how to best engage with parents. I set the bar really, really low. I talk about if you can get on the floor 5 minutes, 5 or 10 minutes a day, that is all we need. That's where we start, right? And it's about empowering them to do very, very small changes initially, because yes, they are overburdened and they are stressed. And so if we can start small, then we can start to have a bigger impact.
Building off of that, any recommendations on how to build upon, for example, resources that may support individuals in this age group? I'm thinking like Head Start, infants and toddlers, and how to kind of encourage parents to seek out those resources if their child qualifies.
I know, I feel like I'm just batting it to social work. That's typically what I do. There are so many resources for families. And so I think if you can figure out in your area what those are, and I see feedback as intervention. So maybe we're going on the website or I'm physically showing families what I'm talking about during feedback. That's going to be a good head start for them, is to be able to just show them the linkage before they even leave your office. Does anyone else have other ideas?
I agree with that. I think that that's where a lot of, at least particularly in early development, but I also think of like a lot of our transition age practitioners, that really kind of sit down, go through, apply for services, kind of set them up for success. All right, and if we think about this as a transition period as well, you know, transitioning eventually to school,
Yeah.
any resources and we can implement to help families with that is going to be important. I don't see any other questions at this time, but I do want to kind of quickly put in a plug. There's a survey in the chat. Please fill out. It helps us really inform future ANST programs and webinars. But if anybody else has any other questions, feel free to ask them. But I want to thank you, Dr. Hamner, for giving this wonderful, comprehensive overview in such a succinct manner. Like, I really appreciate it.
Thanks. I'm so happy to. I've been invited.